Welcome, everyone. I'm Dr. Jung-sik Son from Hanyang University Hospital in Seoul, Korea. Today, we will discuss effective strategies for preventing and managing chronic kidney disease in primary care. Our discussion will cover both non-pharmacological and pharmacological approaches to effectively manage this prevalent condition. Let us start with a case study that highlights the complexity of CKD management. We have a 57-year-old male patient, a construction worker, who presents with a BMI of 30, indicating obesity. This patient's dietary habits include frequent late-night snacks and regular alcohol consumption, drinking a lot of cola during work hours. Recently, he was diagnosed with diabetes during a routine health checkup. Upon further evaluation, these patients had several concerning symptoms and test results. He has a waist circumference of 97 centimeters and experiences severe snoring, accompanied by frequent episodes of apnea, suggesting obstructive sleep apnea. His clinical assessments showed elevated blood pressure at 145, and laboratory tests indicate diabetes with an A1C level of 8.7%. Furthermore, he has signs of fatty liver on ultrasound and albuminuria. Chronic kidney disease, or CKD, is defined as abnormalities in kidney structure or function present for more than 3 months. It is important to recognize that CKD has a spectrum of pathophysiological processes reflected by markers such as decreased glomerular filtration rate and increased albumin to creatinine ratio. We must actively seek the underlying causes of CKD to tailor our interventions effectively. Diagnosing CKD involves confirming the persistence of kidney damage over at least 3 months. This chronicity can be established through a review of past medical records, including measurements of GFR and albuminuria, kidney imaging results, and, in some cases, kidney biopsy findings that may show pathophysiological changes like fibrosis and atrophy. Accurately estimating glomerular filtration rate is very important in managing kidney disease. Combining markers such as creatinine and cystatin C, known as the eGFR creatinine cystatin, provides a more precise assessment of kidney function. This method is particularly valuable in complex cases. For practical daily application, I recommend the KDOKI eGFR calculator. The GFR calculated using creatinine alone was 67, but the GFR calculated using the creatinine and the cystatin equation was 58, indicating that the case patient had CKD. From now on, we will talk about the management of people with or at risk of CKD. Managing CKD requires a comprehensive treatment strategy that includes patient education, lifestyle modifications, and pharmacotherapy. This integrated approach is designed to slow the progression of kidney disease and manage its complications effectively. We recommend significant lifestyle changes for patients with CKD, which include quitting smoking, abstaining from alcohol, avoiding late-night snacks, and choosing water over sugary sodas. Encouraging regular activity, such as walking at least 10,000 steps per day, and maintaining adequate hydration are also crucial. A dietary approach that emphasizes higher consumption of plant-based foods and lower intake of ultra-processed foods can markedly benefit patients with CKD. Such a diet helps managing complications related to progressive kidney disease, such as acidosis, hyperkalemia, and hyperphosphatemia, while minimizing the risk of protein energy wasting. Blood pressure management should be tailored to each patient's individual circumstance, particularly in those with frailty, high risk of falls, or limited life expectancy. Customizing treatment targets can significantly improve the patient's overall management and quality of life. In terms of pharmacotherapy, the use of renin-angiotensin system inhibitor and sodium glucose cotransporter 2 inhibitor are well-supported options. RAS inhibitors and SGLT2 inhibitors are cornerstone therapies in CKD management. These treatments not only delay the progression of kidney disease, but also confer cardiovascular benefits, particularly in patients with concurrent heart failure. Sodium glucose cotransporter 2 inhibitor can lower blood glucose level, reduce body weight, and lower blood pressure by inhibiting proximal tubule glucose reabsorption and promoting regular urinary sodium and glucose excretion. SGLT2 inhibitors have been shown to significantly reduce atherosclerotic events, hospitalization for heart failure, cardiovascular and total mortality, and progression of chronic kidney disease. Educating patients on the effects and the side effects of SGLT2 inhibitors is essential. These medications help control diabetes, blood pressure, and body weight by excreting glucose and sodium through urine. Patients should be made aware of potential side effects like vaginitis and genital infections, and the crucial importance of maintaining proper hydration. Patients should know the importance of maintaining proper hydration. The patient had hypertension and CKD, so he was prescribed a combination medication that includes an ARB. He was also prescribed a combination drug that included an SGLT2 inhibitor because he had diabetes and CKD. The patient's LDL cholesterol was high, so he was prescribed a combination drug that included a statin. Patients taking ARBs and SGLT2 inhibitors may initially experience a decrease in eGFR. Therefore, when ARB and SGLT2 inhibitors are first prescribed, baseline creatinine and potassium should be measured, and the creatinine and potassium should be followed within 2 or 5 weeks of initiation. If the eGFR decreased by less than 30% after follow-up, the medication should be continued rather than discontinued. Performing a medication review for CKD patients is essential to ensure that treatment remains appropriate as the patient's condition evolves. This review should include checking for drug interactions and assessing the continued need for EG medication, particularly because CKD patients often have complex medication regimens. More than any other medication, it is important to educate and ensure that NSAIDs are avoided as they are a significant cause of acute kidney injury and the exacerbation of CKD. In conclusion, the management of chronic kidney disease in primary care requires an integrated approach that balances non-pharmacological and pharmacological strategies to achieve optimal patient outcomes. Thank you for your attention. I'm open to any questions or comments you might have. Thank you.